So, good evening everybody. My name's Alistair. I'm a medical student who's doing some research this year with the Auckland Bone and Joint Group over on Grafton campus. And it's my pleasure to talk to you this evening about my research, which is titled In Vitro Immune Response Screening of Bone Graft Scaffolds. And before I start, I'd just like to thank the Exposure Committee for this excellent opportunity to present my research. So, I want to break down my project, and we need to start with bone grafts. So what are bone grafts? Essentially, bone grafts are filler material. They bridge defects in bone whenever bone loss exceeds the healing capacity of bone. And these free x-rays are from real patients at Auckland City Hospital, and they showcase the three main reasons why we use bone grafts. So over here on the left, we have a woman who had a fracture in her leg, and despite intensive fixation using rods and screws, this fracture hasn't healed. It's caused a non-union, and there's a hole still in the bone. In the middle, this is a man who fell off a motorcycle at high speed, and this intense traumatic injury has caused a hole in the bone which we need to fill up. And over here on the right, we have someone who had a cancer just above the knee. And when we remove this cancer, remove the tumor, there's going to be a hole in the bone, and again we need to fill up the hole. So bone grafts, there's a hole in the bone and we need to fill it up. The most commonly used bone graft right now is hip bone. So this is basically a second operation, but it has two main problems. Firstly, the complication rates are unacceptably high with this surgery. So patients report half the time long-term pain, infection is possible, there's bleeding complications. And secondly, you need bone on your hip, right? We can't take it all off, so we can only take a limited amount. So because of these two reasons, we need alternatives to the current methods. And that's what bone scaffolds provide. So bone scaffolds are essentially just any material that promotes bone healing. And these can be natural materials, which are naturally in the body already, or these can be synthetic materials, which are kind of lab-made, or composites, which are a mixture of the two. And it's a hot topic in orthopedics right now. The current market is a $400 billion market worldwide. And there's two main forms. The ones on the left look a bit more gelatinous, and those are aimed to be injected through the skin. The ones on the right are a bit more solid, more like normal bone, and these are going to be put in more like normal bone grafts. Currently, there's about 50 of these bone scaffolds available to surgeons, but none of them are being used more than the hip bone. Okay? None of them are first-line choices, and this is because they don't work. So immune rejection is often implicated with these bone scaffolds, and last year alone, there was 1 million reports of failure due to immune rejection. So this paper here at the bottom shows complications associated with just one of these bone scaffolds. And in this paper, they show that some patients actually died because of the immune response that was caused. So we have a situation where patients are dying because we are failing to test things properly before we put stuff into their bodies. This is inconceivable. It's absolutely unacceptable, and this needs to be changed. And we believe this is because of the general rush to clinic with the production of these scaffolds. So when they start in vitro or test tube testing, they focus on toxicity. They look at, is this scaffold toxic to bone cells? They don't look at immune cells. Will this cause immune rejection? So because they start off on the wrong foot, when they go down into the human trials, the problem remains and patient safety remains compromised. So the aim of my project was to screen a set of bone scaffolds via immune response assays to predict immune response. So will this scaffold be rejected? Will it be accepted when it gets to the human stage? And of course, the clinical aim being a safer transition from the bench through to the bedside. So we were very lucky at the Bone and Joint Group. People actually give us stuff to test. So we had 6 scaffolds available when I started from across the world. So we had a mixture of synthetic and natural-based scaffolds. Some from the United Kingdom, some from Portugal, and some from New Zealand. So the methodology is actually quite simple with what I did. So I just took some immune cells, put them onto the scaffolds, and then on days 1 and 3, I looked at inflammatory genes and inflammatory proteins. And of course we have controls, don't worry about the negative control. The key to understanding my work really lies with these two positive controls. So firstly, we used a chemical called PMA. Now that is known to aggressively activate the immune system. So this control showed us the level of inflammation we'd expect with immune rejection, okay? And secondly, we used suture material or stitching material, which is used every time a patient undergoes a surgery. And we know this causes some inflammation, but it's acceptable to patients, okay? So this gave us a level that was acceptable to patients. So we had two controls, one showing rejection levels, one showing acceptable levels of inflammation. So this graph shows the three controls at the bottom, along with the 6 scaffolds on the x-axis, and the y-axis is inflammation on a log scale. And we're just going to look at the genes first. So if we look at the rejection control that I just mentioned, it's set up around 300 to 400. So I drew a line across, and that's the levels we'd expect with rejection. If we looked at the acceptable control, it maximized at around 15. So I drew a line across, and anything below that line should be acceptable to the body. So if we looked at the 2 United Kingdom scaffolds, these are well below that line of acceptable inflammation. So we would say, okay, these are okay to move on to the next stage of testing. The 2 from Portugal were a little bit higher, but again, still below the line, which we're saying is acceptable. So they're going to be at least as acceptable as suture material. However, the ones that we tested from New Zealand was very different. The story was very different, and these set up nearer the rejection line right here. And if you remember, this is a log scale. The difference between those 2 values is quite exaggerated. So this is looking dangerous at this point. We're thinking it might not be safe to continue testing these scaffolds. We also looked at inflammatory proteins because it's important to match genes with proteins. And this tells the same story with the 2 New Zealand scaffolds being up at this level of rejection, with the other ones being below the acceptable line. So to summarize, the scaffolds we tested that were from New Zealand, we predict that these will cause an immune rejection, and they're dangerous in their current form. They shouldn't be put through any further. However, the ones from the United Kingdom and Portugal, we're going to say these are safe, and so they're okay to process on further. Importantly though, these 2 scaffolds from New Zealand were due for animal studies this year before I started. And this is because they did some toxicity tests, and they found that they didn't kill bone cells, okay? So they didn't look at immune cells, they looked at, does it kill bone cells? It didn't kill bone cells, they decided to do animal studies. But because of this immune screen work, they've now prevented that from happening, and the scaffolds are now being redesigned. So to conclude, we was able to identify unsuitable scaffolds and prevent unnecessary animal studies, not only saving valuable animal life, but also experimental time and money. I've just put up a couple of things for how I can improve, because of course you can always improve. Firstly, when the scaffolds come in, we sterilize them, okay? So we do sterilize them, but there's something called endotoxin, which remains if present initially, okay? So if that is still in there, it's going to cause a false positive result, okay? So the results aren't true. So we have to still test for that to rule out contamination. And secondly, if we just increase the number of inflammatory genes and proteins that we are looking at, we can increase the validity. So I wanted to end on this slide where I showed this paper saying that some patients were dying because we're not testing things properly. So because we was able to identify unsuitable scaffolds in this work, I believe that if we hadn't have done this, those scaffolds may have got through to clinic and patients may have died because of it. So I also believe we should start now using immune screening as standard for any bone scaffold that comes through, so that we can ensure complete bench right through to bedside transition of safety. I'd just like to acknowledge my 3 supervisors, the Auckland Bone and Joint Group, some visitors we had along the year, in the year, and also my funding sources. And with that, I'd like to conclude my presentation, and I'd like to open up the floor for questions.
between those three different country scaffolds, though?
Yep, what was the difference between them?
Yes.
Yep, so there was quite a lot of things different, right? So the Portuguese ones are based off natural materials, okay? So one of them is actually made of starch. The other ones are purely synthetic polymers. And the pore size is different between each one. So let's go back to this photo. So see on the right, there's pores in that scaffold. And that's because the blood needs to get in and it needs to put cells in there and it needs to then form new bone. Those pore sizes are different between the scaffolds as well. And the ones that seem to be failing have very, very small pores. And we think that's actually the reason that's causing this trouble, yeah.
So is that obvious between New Zealand and the other two countries? The ones that I don't know, the New Zealand ones are quite...
Oh yeah, they're like nanometer small. Yeah. There's a big difference.